Hi, welcome to AETCM YouTube channel. The session for today is regarding general management of poisoning. Any patient presenting to ER, may it be a patient with suspected overdose or a toxicological patient or any other patient, we usually start with assessing the patient's general condition. The key question we ask is whether the condition is life-threatening or not. A life-threatening condition can mean the patient might be in a cardiorespiratory arrest. Then of course you move on with the resuscitation upfront. So the assessment begins with the classical A, B, C and D. So A for airway, the assessment and management of airway, B for breathing, C for assessment and management of circulation, and D is any depression of CNS. We will come on to the various aspects of what and how we assess each things. One of the key methods for assessment of sensorium or the conscious level, which has been classically described, is the Glasgow Coma Scale. You all know, most of you know about it. Classically, it has been described in assessment of trauma patients, but it has been extended to assess in patients who are presenting with a drop in consciousness. The other score is Reed's classification. We will see both of them. So the classical score of Glasgow Coma Scale, to a score of 15, it has three basic parameters. You start with E. E is for eye opening. So whether the patient is opening his eye spontaneously, then the score is E4. If the patient is opening his eye to speech, it is E3. To pain is E2. And if there is no eye opening or no response, no eye scope, then it is E1. Moving on to motor score, if the patient obeys a command, a verbal command, then it is M6. If he localizes pain, it is M5. If there is withdrawal response to a stimulus, then it is M4. If there is abnormal flexion, it is M3. And if it extends to a stimulus or pain, it is M2. And if there is no response, it is M1. So an eye score of E to 1, E4 to E1, and a motor score of M6 to M1. Then you have the verbal response, that is a V. So if the patient is fully oriented, you give a score of V5. If it's confused conversation, it is V4. If the patient is saying inappropriate words, it is V3. Incomprehensible sounds, it's V2. And if there is no response, it's usually equated as V1. So a Glasgow Coma score can have values of E, M and V, and ranging from 3 to 15. That is, 3 could be a deeply comatose patient to 15, which is a fully conscious patient. But another popular classification is the Reed's classification, which ranges from group 0 to group 1 to 2 to 3. So group 0 is basically arousable. Group 1, he responds to painful stimuli and have intact reflexes. Group 2 do not respond to painful stimuli. Most reflexes are normal. And group 3 do not respond to painful stimuli and most reflexes are absent. So this is the Reed's classification of comatose patient, and group 4 is a patient who is deeply comatose with respiratory and circulatory failure. So it is group 0, 1, 2, 3 and 4. Moving on to further assessments, you have to assess the respiratory system. So the adjuvants to respiratory system usually comes in with the measurement of blood pH, a PCO2 level and bicarbonate level. Usually these three values you will get with what is called as the blood gas analysis itself. So you get the pH level, you get the PCO2 level, and you get the bicarbonate level. And other common thing which can be tried is a Wright's pyrometer. Moving on to cardiac status, the key parameters we assess in the cardiac status is the patient's pulse, the blood pressure and the urinary output. So we will see what are the drugs which influence all these parameters. First, regarding the cardiac status. So the key parameter in cardiac status is the heart rate. So there can be rapid heart rate or tachycardia, or a slow heart rate called bradycardia. So for tachycardia, some of the common drugs which can cause toxins which can cause tachycardia are alcohol, datura, nicotine, and salicylates and sympathomimetic drugs. And bradycardia, common things you need to keep in mind is organophosphates, opiates, digitalis and aconite. Moving on, what are the drugs which can affect the blood pressure? So again, hypertension and hypotension. Hypertension, the common drugs will include cocaine, nicotine, amphetamines, And in hypotension, you can remember diuretics, ethanol, opiates, sedatives and hypnotics, and also as common sense says, a overdose of antihypertensives and also antipsychotics. So that is regarding the heart rate and blood pressure. The other parameter which can help us assess regarding the cardiac status or the cardiovascular status is the urine output. So if there is decrease in urine output or oliguria, then the common drugs you need to keep in mind are barbiturates, carbolic acids, ethylene glycol, oxalic acid, salicylates and sulfonamides. And the key parameter is in change in body temperature. So what are the common drugs which can cause either hyperthermia or hypothermia? So for hypothermia, the common drugs would include CNS depressants, opiates, carbon monoxide, barbiturates and anesthetic agents. And hyperthermia can be caused by cocaine, salicylate, phenothiazines and also amphetamines and anticholinergics. So that is drugs which cause hypothermia and hyperthermia. Another very important, both in clinical aspect and also from an exam point of view, is eye changes. So you have your pupillary status, that is a dilatation of the pupil or a constriction of the pupil. So let us see what are the common drugs which causes miosis. Some of the common things which you need to keep in mind are barbiturates, caffeine, chloral hydrate, ergot, nicotine, opiates, organophosphorus and phenol. The common among them is going to be your organophosphates. Mydriasis. The drugs which can cause mydriasis are alcohol, amphetamine, antihistamines, botulinum toxin, carbon monoxide again, cocaine, cyanide, datura and ephedrine. So these are some of the drugs which can cause meiosis and mydriasis. And then there is a popular question of what causes hippus or dancing pupils, that's changing between mydriasis and meiosis. So the answer for that will be aconite. It's not something which we very commonly see in clinical practice though. Another common question which can come up is based upon the breath odor. So if you have a garlicky odor, it could be suggestive of organophosphorus or thallium or arsenic. Then if you have a sweet or fruity odor, it can be suggestive of ethanol or chloroform of nitrates. Bitter almonds is usually suggestive of cyanide poisoning, and fishy odor for zinc phosphate and so forth and so on. Other important parameter which comes into consideration will be the color of the urine, which again the classical thing which you need to remember is the red color of rifampicin and smoky of phenols, and the green color or the blue color of methylene blue and the green color in propofol. So these are just some of the key questions which can be answered, which can come up in the exams. Another very important thing from a clinical perspective is metabolic acidosis. So basically you have a low pH and a low bicarbonate in your blood gas. So what are the common causes of metabolic acidosis in the purview of a toxicological patient or a toxicological victim? So you have your acetyl salicylic acid, you have carbolic acid, ethanol, ethylene glycol, isopropanol, methanol, oxalic acid and sulfonamides. The key thing here to remember is regarding the anion gap. So classically it causes the high anion gap acidosis. So as you all know, pH less than 7.35 is usually considered as acidosis, and you calculate the anion gap by calculating the sodium plus potassium minus bicarbonate plus chloride. The normal range is between 12 to 6, and if the value is more than that, we usually call it as HAGMA or gap acidosis or high anion gap acidosis. And the mnemonic commonly used to remember the causes of HAGMA is mud pies. So M for methanol, U for uremia, D for diabetes, P for paraldehyde or fenformin, I for idiopathic lactic acidosis, iron and isoniacids acid, E for ethanol, ethylene glycol, S for salicylates, solvents and starvation. So this is very important the perspective of exam and also in clinical practice. So moving on to the other general management of poisoning. So as we told, an assessment of patient's condition is very important, and moving on to the general treatment measures, we start with again the respiratory failure. You clear your airway. You can see the picture at the right upper corner, which is head tilt. So what usually happens is as the patient's sensorium goes down, the tongue may fall back and can obstruct the airway. So it's clearing the airway is very important in the management of the patient. So you position the patient correctly. You can use adjuvants like an oropharyngeal airway, which can aid to keep the airway patent or open. If there is pooling of secretions, you can aspirate the secretions, and of course if the conscious level is low and the respiration is compromised, we move on with what is called as endotracheal intubation with a cuffed tube and to secure the airway. Yes, if the patient is having a low oxygen level or hypoxemic, we can move on with oxygen therapy. Or if the PCO2 is high, usually it warrants an intubation, especially when the patient's conscious level is low. But if the patient's conscious level is okay, you can try with non-invasive ventilation also. There is classical concept of analeptics, but it has very, very minimal clinical value as we stand today. Moving on to circulatory failure, yes, it's very important to correct the acidemia. So as we discussed earlier, the patients with a drug overdose or injection of toxins can present with acidosis also. It is key to correct the acidosis, especially we will see in the coming slides how what are recommended for the same. Other thing is to keep the patient on a Trendelenburg position once the BP is low, moving on plasma expanders and also vasopressors. So this is the classical Trendelenburg position. If the patient is hypovolemic, we keep the patient in a Trendelenburg position to assess for the change in blood pressure. And the next thing is, I briefly mentioned about bicarbonate also. So bicarbonate, if the pH is less than 7.1, there can be an indication for bicarbonate. But if the acidosis is not getting corrected with the bicarbonate, then we might need to move on with other measures, including hemodialysis. And if the BP is not improving in spite of adequate volume resuscitation, of course, vasopressors might be needed in the management of the patients. So another key thing in the management in ER itself is the management of hypothermia. So mild cases can be managed with warm room and blanket. Severe cases might require active reheating, including warm water bath or central core heating. If the patient is hyperthermic, of course, you need external cooling measures like ice, cold water bath, apart from pharmacological interventions. So this is again regarding the management of metabolic acidosis, which I had mentioned already, and management of convulsions. Yes, as you all know, toxicological patients can present with symptoms of convulsions. So you manage with your diazepam, which can be given IV, IM or perrectally. And if it is refractory, move on to phenytoin and follow the classical management of seizures in any other patient. So at times the seizure may be so much severe that it might impede with your ventilation. In those situations, we might also consider paralytics to help in controlling the seizures. Moving on, but always remember the other measures, adjuvant measures, which include correction of fluids and electrolyte disturbances, and also other supportive and nursing care. So that was a quick overview of the general management of poisoning patient. But in the next session, we will move on and discuss in detail the general management of poisoning with specifics to decontamination, including emesis, gastric lavage, activated charcoal, forced diuresis, catharsis, and also hemodialysis, hemoperfusion, and exchange transfusion. Thank you.